So this instrument is called as the nasal packing forceps. It is also called as Tilly's nasal packing forceps. So whenever you want to introduce a gauze piece into the nasal cavity, remove from the nasal cavity, this is the main instrument that is used. So it is used for various purposes like nasal packing in cases of epistaxis, for introducing a tampon in the nasal cavity, for doing nasal packing while you're operating. So this forceps is also called as the nasal packing forceps because with the help of this forceps you can introduce in and out the ribbon gauze. Now let us see the instruments that we use for adeno tonsillectomy. For adeno tonsillectomy, first the patient is kept in the rose position. So we will see the positions in the other section, but now let me just begin with the instruments. So when we are doing an adenoidectomy or a tonsillectomy, we have to open the mouth. So for opening the mouth, we have got a mouth gag. This is called as the Boyle-Davis mouth gag. So this is kept in the mouth of the patient. So this is hooked between the upper teeth. So this comes on the upper teeth, and this one will have the tongue blade. So this is the tongue blade that goes into the mouth gag. So this hooks the upper teeth of the patient. This retracts the tongue of the patient. Now you will introduce it first in the closed position into the mouth, and then slowly you are going to widen the opening of the mouth as much as it is permissible. Once the mouth is opened, it is fixed. So this is the Boyle-Davis mouth gag with a tongue blade. The tongue blades again come in various sizes and various patterns. We have got a Doty's tongue blade which has got a serration in between to hold the endotracheal tube. Now if you have done a nasotracheal intubation, you can use this blade. But if you have done a per-oral endotracheal intubation, how can you use this blade? Because it will compress the tube. So there is a tongue blade which has got serration or which has got a slot in between. That slot in between will be holding the endotracheal tube. So this instrument is called as the Boyle-Davis mouth gag with the tongue blade. Now when the mouth gag and the tongue blade are in the mouth, you want your hands to be free and your assistant's hand to be free. So to keep your hands free and the assistant hands free, we have got this Draffin's bipod. So this bipod is inserted into the gag and fixed upon the plate. So this is your McGorran's plate. This is placed below the neck or below the shoulder of the patient. So the McGorran's plate will hold the bipod, the Boyle-Davis mouth gag into the oral cavity. So when you do this, your patient's mouth or the mouth opening is fixed and you and your assistant's hand can be free. So this is called as the So this is your Boyle-Davis mouth gag. This is your tongue blade. This is the Draffin's bipod which is helping you fix the mouth gag, and this is the McGorran's plate over which the bipod stands are fixed so that the entire field of area is constant and nobody is opening and closing, and your visualization is going to be constant throughout the surgery. So if you want to have an increased exposure, you may release the gag intermittently and you may do the procedure as it is convenient to you, but most often once you have fixed the tongue into the position, once you have fixed the bipod into the position, you don't need to do anything, you can proceed with the surgery. Now once you have done this fixing of the bipod on the stand, the next procedure will be to pull the tonsil medially. So to pull the tonsil medially, we have got the Dennis Brown tonsil holding forceps. So this instrument is called as the Dennis Brown tonsil holding forceps. So it is similar to your Lux forceps, but it is used to hold the upper pole of the tonsil and pull it medially towards the midline. And you see the edges are blunt. Okay, so the edges are blunt so that it does not cause trauma to the tonsillar mucosa. So it is used to hold the tonsil and pull it medially. And the second thing is the upper you see there is a difference between the cavities of the upper arm and the lower arm. The upper arm is slightly smaller as compared to the lower arm. So the edges are blunt and the upper jaw is smaller as compared to the lower jaw, and the third one is it has a box like mechanism. So it is going to pull the tonsil medially. Once you have pulled the tonsil medially, you are going to make a incision with a 15 number blade on the upper pole of the tonsil. Now once you have made an incision on the upper pole of the tonsil, you are going to use this dissector. So this dissector will help you separate the tonsil from its bed. The bed of the tonsil is formed by the superior constrictor muscle. So once you have held the tonsil and pulled it, dissection is proceeded with the help of this tonsillar dissector. Now if you want to retract the anterior pillar, you can use this anterior pillar retractor. So you can retract the anterior pillar and see if there are any surfaces of bleeding. So anterior pillar retractor is used for looking for any underlying bleeding surfaces. So we'll go to this instrument later, but this instrument is called as the Dennis Brown tonsil holding forceps. So main thing is you are going to see the upper jaw and the lower jaw. The upper jaw is smaller as compared to your lower jaw. Now this instrument is called as Mollison tonsillar dissector and pillar retractor. So this is used for atraumatic dissection of the tonsil from the tonsillar bed, and this end is used for retracting the anterior pillar, because you want to see the bed of the tonsil, if there is any tissue that is left behind, if there is any bleeding spot that is present. So to identify that, you are going to use this instrument, which is called as the Mollison tonsillar dissector and the pillar retractor. Now once you have used this dissector and pillar retractor and you have gone till the lower pole of the tonsil, so you started from the upper pole, dissected till you reach the lower pole. Now you have to cut the tonsil, right? So how are you going to dissect or cut the tonsil from the lower pole? You are going to use this snare. This is called as Eve's tonsillar snare. So you are going to engage the tonsil between the wires of this snare. So depending upon how big or how small is the tonsil, you are going to hold the tissue in between the snare, and then you are going to cut the tissue. So I am not going to cut my finger, but I am just going to show you the instrument, the tissue, the tonsillar tissue after having been dissected from the lower pole. The pedicle is held like this and then it is crushed. Once it is crushed, the tonsil is out. Now once the tonsil is out, you have to look at the bed to look for any bleeding surfaces. So if there is any superficial bleeding, you can use this straight artery forceps. So wherever is the bleeding area, you are going to hold it with the straight artery. So once you hold it, you are going to put a tag or a knot below it and you are going to ligate the bleeding vessel. But certain times there may be a deeper bleeding that could occur as well. So to stop the bleeding, the deeper bleeding, you will have to put a straight artery. Now assume that there is a deeper bleeding. I will put the straight artery to hold the superficial bleed first, but still the bleeding continues. So I have to ligate the deeper vessel. So I am going to take this Nagus artery forceps, which is like a J shaped. So I am going to pass this forceps below the bleeding vessel. Now once I go below, you can see I have gone quite deep, or I have gone quite inferior to the straight artery, and I have accessed the bleeding point. Now once I have accessed the bleeding point, I am going to remove my straight artery and going to keep it aside. Then with the help of a knot and a tie introducer, I will introduce the tie below the surface and I will ligate the bleeding vessel. So whenever there is a bleeding that is occurring from the tonsillar fossa, you can use either a Nagus artery forceps, which is the second artery forceps. This is the Burkitt's first artery forceps. So the first artery forceps is straight, the second artery forceps or the Nagus forceps is curved. So that's the difference between in between these two forceps and how to control the bleeding, which has to be used first and which has to be used later. So with this, I hope you have understood the procedure of tonsillectomy, you have understood the instruments that are necessary for tonsillectomy. When you are doing a tonsillectomy, you also need probably combine the procedure with an adenoidectomy. The procedure is more or less the same. You are going to use the mouth gag, open the mouth. Now you are going to take the St. Clair Thompson adenoidectomy curate. Now this St. Clair Thompson adenoidectomy curate has a cage. Why is there a cage here? Because when you are introducing this instrument into the nasopharynx, you are going to hold it like a dagger. You are going to pass it into the nasopharynx and curate it out. Now once you have curated the tissue out, you don't want the tissue to get aspirated or go into the lower airways or into the oropharynx or below anywhere. You want the tissue to be engaged here and be left here. So to keep the tissue in place, you are going to use the St. Clair Thompson adenoidectomy curate with cage. And whenever you are curating, it has to be gentle movements. It should not be very strong movements, as it may traumatize the muscle of the posterior pharyngeal wall, and sometimes it can even cause injury to the atlantoaxial joint. So you have to hold it like a dagger, and sweeping motion has to be done from superior to inferiorly to remove the adenoid tissue. You have also another instrument which is similar to this instrument, but it comes without a cage. So a adenoidectomy curate can be there with cage, it can be there without cage. Without cage is used when you are going to remove only the remnants of the tonsil, not the main bulk of the tonsil. So when you want to remove the remnants of the tonsil, you are going to use without cage. You are going to use with cage when you are going to remove the main bulk of the tonsil. Now when you have done a tonsillectomy or adenoidectomy, obviously it will bleed. So to suction it, you have this suction cannula which is called as the Yancour's suction cannula. So this Yancour's suction cannula is used to suck out the blood which is there in the oral cavity or the oropharynx or the nasopharynx. So this is called as the Yancour's suction cannula. So for doing a tracheostomy, I will be showing you a live surgical or a true surgical procedure of the tracheostomy, where you will understand all the instruments, but there is one instrument that you need to very clearly understand in relation to tracheostomy. After having made an incision and dissecting the skin and subcutaneous tissue, you are going to dissect the strap muscle with the help of artery forceps. Now once you have gone and reached the isthmus, you are going to retract the isthmus with the help of this single hook. Now what I have is a smaller single hook because I prefer to use one because I don't want to cause trauma to the isthmus, but you can use a bigger hook as well. So this is basically a skin hook which I use for retracting the isthmus, but you can use the bigger hooks as well. Once you have reached the trachea and you want to make an incision between the second and third tracheal ring, you make a stoma. Now once you have made an opening in the stoma, you have to dilate the opening. So you have to dilate the opening with the help of this dilator which is called as Trocheus tracheal dilator. So with the help of the tracheal dilator, you are going to dilate the stoma of the trachea or widen the tracheal opening. Once you have dilated the tracheal opening, now you can introduce your tracheostomy tube in situ. So that is the use of this instrument. The instruments that I am using here or showing you now are called as the laryngoscopes. So this laryngoscope is introduced per orally to visualize the larynx or the vocal cord. So this is a rigid instrument. This is a rigid laryngoscope used for microlaryngeal surgery. So first you are going to put a light source to this. So I'll show you the light source. So this is the cannula for the attachment of the light source. This goes into the port here. Once you have attached to the port, you are going to connect it to the light source, and then under visualization you are going to go down and you are going to fix on the vocal cords. Once you have visualized the vocal cords, now you are going to connect this to a chest piece. So there is a chest piece that comes on the chest of the patient and that is fixed here to the slot behind. Once you have connected to the chest piece, this remains as it is. You can have an assistant to hold it, but otherwise it remains fixed. It will not cause any problem. So this will leave 2 of your hands free to perform your microlaryngeal surgery. So this is called as clean saucer suspension laryngoscope.